Today we're going to talk about the endoscopic Indonesial approach for the treatment of tuberculum Sellae meningiomas. We must remember that tuberculum Sellae meningiomas arise from the tuberculum Sellae and typically displace the optic nerves posteriorly and superiorly. Because of this anatomical relationship, the endoscopic Indonesial approach have represented an excellent surgical option for some tumors that are, especially those that are smaller and that midline or medial to the optic nerves or carotid artery. So when performing this approach, there are two anatomical landmarks that are particularly relevant. When we move from the transcranial perspective to the endonasal view, we need to understand what anatomy we will actually see from below. Essentially, the surgical field corresponds to the region of the planus sphenoidale, the tuberculum Sellae, and the limbus sphenoidale. This is essentially the midline corridor that allows to access to these tumors. And laterally, we are going to identify other two key structures, which are the optic protuberance and the carotid protuberance. Between them lies the opticocarotid recess, which has two components, a lateral opticocarotid recess and the medial opticocarotid recess. The lateral opticocarotid recess is easy to identify in well-pneumatized sinus, but it doesn't carry the same relevance in the surgery of tuberculum Sellae meningiomas. The medial opticocarotid recess, in contrast, is not such as a bony depression, but it marks the transition between the medial aspect of the optic canal and the carotid artery. And as such, it helps to define the region of the paraclinoid carotid and the distal and proximal dural ring. And why this is important? So if you don't expose this region properly, you are operating in the parasellar space without a clear understanding of where the intracavernous carotid ends and the supraclinoid carotid begins. So you might start pulling from the tumor and indirectly pulling from the carotid artery that is attached to the distal dural ring and potentially have a poor view or even have an injury on the internal carotid artery. So we agree upon that the medial opticocarotid recess marks the distal and proximal dural ring, and it needs to be exposed in every single case in which we approach a tuberculum Sellae meningioma through an endoscopic endonasal approach. But what is the other structure that is relevant from the bony landmarks that we mentioned above? That's the medial clinoid process. This bony depression marks the origin of the carotidoclinoid ligament. It's separated from the medial opticocarotid recess, and from there it marks the superior edge of the cavernous sinus, and therefore needs to be exposed in every case in which there is invasion of the cavernous sinus and we attempt to remove tumor from inside this structure. So today we are going to see an example about how to expose these key structures in a case for a patient of 40 years old who presented with a cerebral coronary nerve neuropathy, and there's no meningioma invading the cavernous sinus, the tuberculum sella, and the diaphragm. So first of all, we expose the endonasal structure after our colleague, Dr. Stavrides, did the endonasal portion of the case. All right, this is time for a
shameless self-promotion.
If this looks like magic and you are thinking how you even get here, I explain in a step-by-step in a video down below. You can find the link in the description. Now let's back into real surgery. And we are seeing the midline structures, including the planum and the tuberculum sellae, and we localize the middle clinoid process. We have also localized the lateral opticocarotid recess, and here is not drawn in this skin, but we see the middle opticocarotid recess. So now we are just removing the bone with a diamond drill for the anterior aspect of the cavernous sinus, and we are using the Kerrison Rungier to remove the bone of the tuberculum sellae all the way here to make sure that we expose the middle opticocarotid recess in the right side as well and in the left side. And this way we also expose the middle aspect of the cavernous sinus. Now with the drill, we're just going to drill in the direction of carotidoclinoid ligament, taking care of the medial clinoid process. And by doing this way, we know that here we mark the superior margin of the cavernous sinus. So we are going to incise the external dural layer of the meninges, and this way we are going to enter the cavernous sinus. Here the tumor is expanded the cavernous sinus itself, so there is very little room for the blood to come out. Still, we need to do some hemostasis of the cavernous sinus, and as we move forward, we just elevate the external dural layer to expose the tumor that is involved in the mid portion of the sella. And here with Angelina number 1, we're just trying to find the margins of the tumor, hopefully with the hope to find the pituitary gland. Here I'm coagulating the inferior parasellar ligament, and I continue my dissection in the direction of the diaphragm. And now by cutting the superior intercavernous sinus on the diaphragm, we access the suprasellar portion of the tumor. Here we're having some CSF, and I continue my dissection, just trying to find the margin of the gland. This is a patient already radiated and with a hypopituitarism. So we see that the tumor is actually infiltrating quite extensively the pituitary gland, and it's difficult to find a margin. I continue my dissection medial to the left internal carotid artery, and I go again trying to find a limit with the pituitary gland. Here we see interexposure, the draws of the internal carotid artery and the cavernous sinus and the tuberculum cellar for an orientation, and where the mid clinoid was before we remove it, and how this marked the superior limit of the cavernous sinus. And here we have the LOCR, and how the LOCR, besides the MOCR, marks the limits of the paraclinoid ICA. So as we move forward, we have identified only the stalk. The gland is densely infiltrated by the tumor, as the patient was panhypo. There is no point to try to preserve the gland, but it's important to try to preserve the stalk so the patient doesn't develop a post-op DI. So we are mobilizing the stalk with sharp dissection, and we bring the tumor down to avoid the traction from the optic apparatus and the stalk itself. As we move backward, we feel that we are reaching the posterior aspect of the sella. We see the diaphragm that has been previously cut, and we remove the tumor from inside the sella, and the portion of the suprasellar, that portion of the tuberculum cellar meningioma that has been already removed. We'll see how the mammillary bodies are seen in the back, and the remnants of the cortico-clinoid ligament, which we know it marks the superior limit of the cavernous sinus. We proceed with the hemostasis of the cortico-clinoid ligament to ensure that there are no branches from the ICA coming up, and we remove the last few fragments of this tumor. Here we find the posterior communicating artery, and we are just going to focus now our intention to remove this portion of the tumor invading the superior compartment of the cavernous sinus, as we see here. It seems to be like a different tumor, but it was the same tumor invading the tuberculum cellar and also the cavernous sinus. So we proceed with some hemostasis between the carotid artery and the tumor mass, which were probably afferents to the tumor. And after mapping the internal carotid artery, we proceed with sharp dissection to remove the tumor from the posterior and superior compartment of the cavernous sinus. Here we complete the hemostasis of the cavernous sinus. We can ascertain that we achieve a complete resection, preserving the stalk. We do a 3-layer reconstruction. Here we're using the fascia lata, followed by the nasoseptal graft that was peeled off by our colleague, Dr. Stavrides. After the surgery, the patient did well, did not develop any post-op DI. He remained panhypo, and the vision improved. Thanks. Subscribe and share with your residents if you would like me to keep making more of this. Have a nice weekend.